Hi, everyone, and welcome to the Otolaryngologic Clinics Podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the April 2023 issue dedicated to larynx cancer, guest edited by Drs. Kost and Gina Jefferson. Here now is the series consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today, I'm speaking with the guest editors of the April 2023 issue on larynx cancer, Dr. Karen M. Kost and Dr. Gina D. Jefferson. Dr. Kost is professor, Department of Otolaryngology, Head and Neck Surgery, McGill University Health Center, Montreal in Quebec, Canada. Dr. Jefferson is professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Mississippi Medical Center in Jackson, Mississippi, in the United States. Welcome to the podcast, Karen and Gina.
Thank you, Sujana.
Thank you.
So listeners of our podcast will be familiar with this particular next line of mine, which is I loved reading this issue of Clinics, and I loved learning in depth about the state of the art for larynx cancer. As you write in your foreword, larynx cancer is the third most prevalent tumor of the respiratory tract in the United States and the second most prevalent worldwide. There are an estimated 12,000 incident cases and 3,800 annual deaths in the United States from larynx cancer. And even though there's been a global decline in tobacco use, in my foreword for this issue, I was traveling and I took a picture of the cigarette cartons at the duty free that have pictures of people with tracheotomies and electrolarynxes and scary pictures to say don't smoke. So tobacco use has declined, but it still remains the most significant risk factor for the predominant laryngeal malignancy, which is squamous cell carcinoma. That decline in tobacco use has paralleled the decreasing incidence of laryngeal cancer by about 2 or 3% yearly. So clearly, we are chipping away, but we still have a problem. So in this issue of Clinics that was published in April of 2023, you two have curated a collection of articles that discuss the diagnosis and management of both early stage and late stage laryngeal disease, including premalignant entities. The articles cover assessment, treatment, surgical and non-surgical organ preservation, prehabilitation before treatment, and rehabilitation afterwards. The goal of care of these patients is life, organ, and voice preservation. So let's go over some of the highlights in this issue. You start off with an article that's written by Law and Schmidt on the anatomy of the larynx and the molecular biology of the larynx. And as I mentioned, everyone's aware of smoking and everyone's aware of alcohol as risk factors for laryngeal cancer. Less well known are some of the other risk factors that can also play an important role. So, Karen, can you educate us as to some of the common and uncommon risk factors for laryngeal cancer?
Thanks, Sujana. Sure. It's really interesting when we look at trends because we're all sort of very focused on what happens sometimes in North America and Western Europe, where, laryngeal cancer is decreasing because of the reduced rates in smoking. But as you pointed out, in other parts of the world, smoking continues to be a big problem. And there, laryngeal cancer is a big problem. What we do know is that for those who quit smoking, obviously, smoking cessation has a very positive effect on risk, lowering it. And laryngeal cancer is thought to pose a minimal risk for those who smoked less than 10 years. And sometimes alcohol is underestimated as an independent risk factor. But we also know that there are several less well-known patient factors associated with increased risk, and these would include things like being a male, being older, having a poor nutritional status, type 2 diabetes, a sedentary lifestyle. So these are not things that we commonly think of as associated with cancer. Other important risk factors include reflux, and I want to spend a minute on this because for a long time, people thought reflux was not an issue. But we now know there have been a few meta-analyses to this point showing that reflux is an important risk factor and should be definitely controlled. There are also occupational exposures that are important, and that's maybe something that we don't talk about. I think asking people what they do is important. So, for instance, exposure to asbestos is a very important risk factor for laryngeal cancer. People who work with solvents, sulfuric acid, firefighting. I mean, look at all the fires right now going on in North America. These firefighters are at high risk for all sorts of cancers, and laryngeal cancer is one of them. And then, of course, there are genetic polymorphisms, and the data on these, of course, are evolving as we speak. They would constitute, at this point in time, at least, a non-modifiable risk factor.
So thank you. I actually like that idea that we still need to make sure we share with our patients that they haven't lost because they've been smoking. And if they can, in fact, reduce or stop smoking, they can reverse or decrease this cancer risk as well as other cancer risks. And we want to thank you down here in the United States of America for the lovely air quality that you Canadians have been sending us.
I want to apologize on behalf of the country.
We're in the operating room. We're all like, what did we ever do to Canada? Why do they have to treat us like this? There's a really interesting concept of prehabilitation. And so, in otology, we talk about prehab for balance before we do, let's say, a vestibular neuroma surgery. But prehabilitation is not commonly discussed when looking at laryngeal cancer. But here you've devoted an entire article by Murray and Kane to the topic. So, Gina, can you help us understand why that's important?
That's a great question, Sujana. Obviously, people are familiar with the term rehabilitation for recovery from surgery, recovery from trauma, or some other physical ailment to help regain function. When patients present with laryngeal cancer, the patient is often presenting already with a functional deficit due to their disease. So really adopting a multidisciplinary kind of comprehensive approach to evaluating our patient's function with the diagnosis of laryngeal cancer prior to the initiation of radiation or surgical-based treatment. It allows the clinician, along with the speech-language pathologist, to devise kind of a swallow and voice therapy program for them. So they begin it before their treatment is commenced, and they continue during their treatment. It's often a home-based exercise program that the patient is instructed to complete every day to best optimize their function before they start treatment, to maintain function that they've regained from their prehabilitation exercises. And then the aim is to obviously help mitigate some of the toxicities related to the treatment that will further impair their function of the voice box, which includes not just speaking, as most people think, but most importantly, airway. And that involves a safe swallow as well.
And, I was reading this article both in the hardcover and online, and there are some supplemental videos that I thought were really interesting that accompanied this article. And there's one on the oropharyngeal swallow, and then there's one on the swallow 10 years after chemo-RT. And I think that long-term understanding of what our surgical and non-surgical interventions are doing is very helpful.
I completely agree. I'm always telling patients that radiation is the gift that keeps on giving, but it's not just radiation, right? Both treatment modalities, whether it's radiation-based or surgical-based, result in fibrosis of the muscles and the surrounding soft tissues that all contribute to the function of our airway. And so even after 5 years, when a patient's disease-free and considered cancer-free, they're still having evolution of the scar tissue that's formed, and that can change how they're functioning. And so it's important to maintain that in the back of one's mind, both patient and provider, so that when a patient does register that concern or complaint, it can be thoughtfully approached and addressed.
Thank you. So, there's some really interesting article I'm sorry, let me go backwards. There is some really interesting information in the article on staging and imaging that's written by Itamura, Shu, Barbua, and Chen. And they cover a variety of imaging techniques, some of which, are quite known to all of us, like computed tomography, MR imaging, nuclear scans. But they also discuss some newer, less well-known imaging modalities. So, Karen, are you able to highlight some of these and how they help with the initial staging of these tumors in these patients?
Yeah, I think that's also really important. Thanks for the question. I mean, some of these tools are really in our backyard, to put it simply. So if we just look at video stroboscopy, for example, it's not commonly viewed as an imaging modality per se, but you can get a huge amount of information. So many centers have video stroboscopy available. And we know that there's definitely research showing that if you've got early invasion with glottic cancer, this will have a deleterious effect on the mucosal wave, for instance. So here's a very simple test you can do in clinic to help you decide the depth of your excision if you're going to operate, for instance. Very, very helpful. Takes 5 minutes. The other thing or the other tool that's commonly available is narrowband imaging. And we don't really talk about it. And I see many people not bother with it, but it's incredibly useful. And there's data to support its use. And it's very nicely discussed in this article. And basically, it's an optical enhancement technique. And what it does is it illuminates intraepithelial papillary capillary loops. And why is that important? It's important because these loops change. We can see them with the blue light wavelength and the green light wavelength that we see with narrowband imaging. And so it highlights abnormal blood vasculature, which you would not be able to see with conventional white light. And there are very specific surface mucosal changes and changes in the vasculature that are characteristic of neoplastic lesions. So in your office with narrowband imaging, you can do a kind of optical biopsy. So that's really cool. And what's been done with this is these changes have been classified into 5 categories, predicting the depth of superficial cancer invasion. And so you might ask, well, how good is this? And in a recent review, NBI, or narrowband imaging, was found to have a very high accuracy rate in both the preoperative setting, 82 to 97%, and in an intraoperative setting, 85 to 95%, in identifying premalignant and malignant lesions. So it definitely adds to and is superior to white light in looking at some of these parameters. And then, so these things are easily available. And then there are things that are not quite ready for prime time, but show incredibly exciting promise. And one of these is optical coherence tomography. And that's a non-invasive light-based optical tool that can provide high-resolution cross-sectional images of tissue using a near-infrared light beam. And it was originally used in ophthalmology, and it's now been adapted in otolaryngology with probes that will eventually be placed through endoscopes and laryngoscopes. And the general sort of concept of this is that light is provided from a source, and then it's split into two arms. One of them is directed at the tissue sample, and the other one at a reference mirror. And the light reflected back from the two arms is compared for coherence. And so obviously, if it's not coherent, then there's a problem or an abnormality. And so various updates have been added to this. And one of this is polarization sensitive OCT, which is an enhanced form measuring both the intensity and polarization of the reflected light and gives you even more detail. So why is this important? Because it can accurately predict the grade of dysplasia in 71% and malignancy in 93% of cases with dysplastic or leukoplakia type lesions. So currently, this is not commercially available, but I think it will one day will be, and shows great promise for use in both the clinic and the operating room. Imagine being in the OR and being able to tell how deep this lesion goes and exactly where your excision needs to stop. The last thing I'm going to mention very briefly is autofluorescence, which is another exciting emerging imaging modality that our readers can look at in this article. And it has ultimately the potential of being a very practical, cost-effective, and non-invasive screening tool for identifying, again, malignant lesions in the larynx.
Yeah, it's so interesting. I think that we are optical coherence tomography in particular is being looked at across mucosa. Maybe I can say it like that, because we're looking at it from an otology perspective, trying to determine, cholesteatoma versus chronic otitis media, and even as simple as trying to help the primary care physician accurately identify acute otitis media versus not acute otitis media. So starting from, a simple infection thing to cholesteatoma to cancer, I think that we're finding that the mucosa that we deal with holds many secrets that we have yet to uncover. That's what it seems like to me when I'm reading this. I will remind our listeners that this article on staging has a really nice table on TNM staging and some really nice pictures, just because for an otologist, I happen to love the laryngeal anatomy, but there are beautiful pictures to really kind of illustrate where and why these newer modalities can help us. So Karen talked about dysplasia, Gina, and you guys included an article on laryngeal dysplasia written by Olson, Alexander, and Stinnett. So can you just explain to us what causes dysplasia currently? How do you diagnose it accurately? And what treatments can you offer or do you offer? And are you doing that to try to be a pre-treater of a possible malignancy? So there you go. Only 4 questions in a row.
The treatment response I will provide is based on a head and neck cancer surgeon's perspective, which is probably a little different than that of a laryngologist. I'm always telling my residents, I am a head and neck surgeon. I'm a wide open, take all the specimen you can and prove a diagnosis of cancer, versus my laryngologist colleague who will use a microforceps. But back to your original first question. As Karen already elucidated earlier in discussing the primary cause for laryngeal cancer, the same holds true for laryngeal dysplasia, which is a precursor of laryngeal carcinoma. Potentially, not all laryngeal dysplasia, which is simply an abnormal finding of the normal mucosa of the voice box, has changed in an atypical way and might not be invasive in the case of laryngeal dysplasia. And there are different degrees. Primary risk factor, again, is tobacco, and then followed closely by alcohol. But there are other things that are also precursors or predispose a patient to laryngeal dysplasia, including industrial exposure, and then industrial exposures with polycyclic carbons, asbestos, I think nickel, cement dust, and then, of course, as Karen also discussed, laryngeal reflux disease. Again, not every patient that is exposed to these risk factors will develop laryngeal dysplasia. About 5% of the population might develop it without any of those risk factors. It doubles if a patient is considered a light smoker, which is considered 10 cigarettes per day or half a pack a day. And it almost approaches 50% for patients who are a 1 pack per day smoker. And so you can see that the risk with respect to tobacco increases with the amount of tobacco exposure. With respect to diagnosis, direct visualization is the best method of recognizing that there's something abnormal about the larynx. And that typically occurs in the office setting with the patient awake in your clinic, where you're using a fiber optic laryngoscope, sometimes a rigid laryngoscope, and that uses white light. Karen also spoke about the narrowband imaging, which many of our fiber optic laryngoscopes are equipped with today, to enhance the vascular pattern of increased vascularity for lesions that are concerning for the development of malignancy. And then there's another form of imaging that also enhances vascular angiogenesis that Karen did not discuss. So I'll talk about that one a little bit. It's called SPIES, which is Storrs Professional Image Enhancement System. And that's based again on the vascular pattern that increases with increasing changes that are leading to malignancy. Ultimately, the diagnosis is performed by biopsy. That can also occur in the clinic. Oftentimes, it is a procedure that's performed in the operating room. It's based upon your clinician's in-office tools, patient comfort level with performing a biopsy while awake. And sometimes it involves the decision-making with respect to airway protection, whether that can be safely done in the office versus the operating room. What was the other part of your question?
So what treatment? So you talked about biopsying it. So now you have a diagnosis of dysplasia. You have a half pack a day smoker, drinks socially, and you can define socially the way you would like to define socially, and is a firefighter. And now they have this dysplastic lesion that you've biopsied, and you don't see malignancy. So what do you do for these people?
Sure. Jam-packed question. So after biopsy, in the olden days, they used to do this thing called vocal cord stripping, which is really kind of frowned upon today because it's destructive. In the interest of organ preservation, we try to do a more conservative approach for managing these patients, particularly since they don't have evidence of frank invasion in discussion of laryngeal dysplasia. So commonly we'll do something called micro laryngoscopic procedure, whether it's use of cold steel or a laser. Laser therapy can be done with either a carbon dioxide laser, most commonly, or a KTP laser. And both are done transorally with the goal of removing the dysplastic lesion while leaving intact as much of the vocal cord as possible. Also, a technique that's in favor is a microflap technique, where elevation of the epithelium is carried out to remove the lesion to preserve as much of the integrity of the vocal cord as possible. And so that's the main treatment regimens that we offer our patients.
So now you've got this person who you thought was dysplastic, and you took them to the operating room, Karen, and they have cancer. So let's talk about early glottic cancer. You have an article on radiation by Schoenwolf and Shah, and one on surgery by Silver, Turk-Duggan, which is, I think, a great name, Roy, and some lady called Kost from Montreal. So decades ago, radiation was the mainstay, right? You had an early T1, you got a little radiation, you sounded a little like this for a while, and then you were kind of okay. But then since then, both radiation and surgery, as I think especially with the advance of microlaryngoscopy techniques, as Gina alluded to, have both become accepted modalities. So Karen, aka Dr. Kost, can you outline what's changed and what might influence a recommendation of radiation over surgery or surgery over radiation for these early glottic cancers?
Yeah, thanks, Sujana, for that really important question. As you highlighted, both radiation and surgery are considered acceptable for the treatment of early glottic cancer. And I think that's one of the most important principles, that it is unimodality therapy. There's no place here really for combined therapy. And, we used to, as you said, radiate these patients. It was a no-brainer. And we know that radiation is associated with consistently high cure rates in the order of over 90% for T1 glottic cancer and 70% for T2 glottic cancer. And then, of course, radiation evolved from being based on two-dimensional plain X-rays to being CT-based. And this allowed for more precise dosing. And then, of course, another major advance was the development of intensity modulated radiation therapy, or IMRT, which allowed more precise shaping of the treatment beam, resulting in a much better dose distribution. And most recently, there's been some talk of single vocal fold irradiation, which could, I think, really revolutionize this treatment. And, overall, for a long time, everybody said that early stage glottic cancer treated with radiation is very well tolerated. And that's true. Severe complications are rare. However, one of the things that's not talked about so much, which we've really come to realize, as Gina alluded to, the gift that keeps on giving, even for very sort of targeted treatment like an early laryngeal cancer, many of these patients end up with laryngeal dysfunction, which is progressive, dysphagia. And one of the things that hasn't been talked about is late cardiovascular events with secondary accelerated atherosclerosis and carotid artery disease and so on. So this is all very concerning. And that led, I think, to a resurgence in surgical options. And as you mentioned, I would say the current gold standard is transoral minimally invasive surgery. It's the mainstay, I think, for early glottic cancer. Why? Because you can do it usually it's one-stop shopping. It's outpatient surgery. And it takes an hour and a half as compared to many weeks of radiation. And you don't risk all those late side effects. In a recent meta-analysis comparing T1 glottic cancer outcomes and CO2 transoral laser microsurgery TLM outcomes versus radiation, results suggested that TLM is the superior modality in terms of overall survival, disease-specific survival, laryngeal preservation, and quality of life. So I think that surgery, gives us a lot more options. If you do a procedure that isn't quite right, you can go back and correct, you can fine tune, you can reoperate, and of course, you've still got radiation as a possibility in your back pocket. On the other hand, patients who've been treated with radiation usually cannot be re-irradiated. And usually those patients end up with a total laryngectomy. Quite unusual to be able to do conservative organ-preserving surgery in these patients. So for these reasons, I think that TLM has probably evolved as a preferred choice, unless there are some compelling reasons that patients cannot have surgery. One of the things that our radiation oncologists used to say all the time is, well, we get a much better voice result with radiation. And I was personally suspicious of that result for a long time. And I think that there are sufficient studies now, including a large multimodality voice analysis that looked at this, suggesting that the outcomes are probably not very different between the two modalities long-term. So in terms of decision-making, certainly if it was my larynx, I would choose surgery. But I think that to be fair with patients, we need to offer them both options. And our treatment decision needs to be guided by their preference after a comprehensive discussion of all the options. So this being said, for patients with early cancer and a low operative risk, I think TLM provides a lot of advantages that we've already discussed. There are some patients that simply are not suitable candidates. So table 1 in the article on surgical treatment of early glottic cancer really puts the two modalities in perspective by highlighting early and late complications of radiation therapy, open surgery, and transoral minimally invasive surgery. But in addition, there are some very nice illustrations looking at the classification by the European Laryngological Society, outlining the different types of chordectomies available for surgical candidates.
Thank you. I think that personalized, every field is going towards personalized medicine, personalized surgery, personalized counseling, and a table such as that one that really compares as best as we can is very beneficial for people who are counseling these patients. So let's move from early glottic cancer to advanced glottic cancer. So Gina, you're on the hook again. So you guys included an article on surgical management by Punia and Nicoli, and one on chemotherapy and radiotherapy by LeBlanc, Thomas, and Buganin. So Gina, can you talk to us about organ preservation versus total laryngectomy in these T3 and T4 cases?
When I think of organ preservation, the authors have highlighted some of my thoughts, which, organ preservation by definition is an assumption that there is functional organ to actually preserve. And again, to emphasize, the primary function of the voice box is not speaking, it is airway. Without airway, we die. And so if you require a tracheostomy because of your laryngeal cancer, you don't have function of your voice box. But that being said, Organ preservation obviously has a role for patients that have function of their voice box they're trying to preserve, with the primary treatment rationale obviously being eradication of disease. And so we think about organ preservation of eradicating disease while maintaining function, as in no dependence on tracheostomy or feeding tube after treatment. I would say that this largely impacts decision-making between the physician and the patient, maybe even more so for early stage T4 disease, but certainly for patients with T3 cancer. The reason I say that is because for T4 cancer, as outlined in Table 1 of the Punya-Nicolai chapter, T4 is described as cancer breaching the thyroid cartilage and invading the extralaryngeal muscles or the base of tongue musculature, for example. And that doesn't describe the breadth of what that represents, right? You can have a small breach of the thyroid cartilage with a small involvement of the extralaryngeal muscles and still have function of the voice box. Hence the caveat of shared decision-making between the patient and the physician. But for organ preservation with respect to stage 3 lesions, they can have surgically based treatment, as Karen outlined, with respect to microscopic transoral laser microsurgery. For advanced stage disease as well, anatomic considerations must be made with respect to maintaining function, right? You have to have preservation of the cricoid cartilage, more or less of it, as well as a functional cricoarytenoid unit in order to have a patent airway. And so surgical organ preservation is not always possible. And then we start to consider chemoradiation as the organ preservation paradigm for advanced stage disease. And that is because radiation alone has been shown through study to not be as effective at survival and local regional control as with combined modality treatment of chemotherapy and radiation provided together, called concurrent chemoradiation.
Very nice. Very nice. And I know when we talked in an earlier podcast about melanomas and basal cell carcinomas of the skin, they were talking about immune checkpoint inhibitors. So where's the role for that in these patients who are primarily squamous cell? The tumors are primarily squamous cell carcinomas.
Certainly. This is an exciting time currently with the emergence of immune checkpoint inhibitors and immunotherapy, not only for mucosal head and neck cancers, but obviously for cutaneous disease. So recently, the past several years, there's been FDA approval for recurrent disease, progression of disease, metastatic disease, unresectable cancer, treated with a combination of chemotherapy and immunotherapy. Now, this has not been deemed a cure, obviously, and there's more studies that are ongoing currently, clinical trials to determine the breadth of the role of immunotherapy as it pertains to head, neck, and mucosal disease. But there are positive signs with respect to regression of disease in the palliative setting, at least achieving a partial response, and in some instances, a complete response by RECIST criteria. So these findings we look forward to from the clinical trials.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm having a great time learning all about laryngeal cancer from the guest editors of the April 2023 issue of Otolaryngologic Clinics of North America, Dr. Karen Kost of McGill University in Montreal, and Dr. Gina Jefferson of the University of Mississippi Medical Center in Jackson, Mississippi. You can find this and all issues of Otolaryngologic Clinics of North America in your institutional library, hopefully in your personal library, and online at www.oto.theclinics.com. And you can find all of our podcasts, which is one per issue since 2017, at that same website or wherever you get your podcasts. On a personal note, I would tell you I love editing these or meeting with the guest editors to go over what the issues will cover. And I love reading the issues and I love doing these podcasts, but I would like to hear from our listeners about how we can do it better. And I'm really happy for any feedback you'd like to give us. So as we continue, we talked about TLM, which is transoral laser microsurgery. People are possibly more familiar with transoral robotic surgery or TORS. So there's an article looking at different approaches and thought processes when facing supraglottic or subglottic cancers. And the articles are by Patel and by Mann, Seligman, Caldwell, Burr, and Glazer. And you've included an article on robotic surgery and laryngeal cancer by Gia and King. So TORS is well established in the treatment of oropharyngeal carcinoma. So Karen, can you talk to us about its role in laryngeal cancer?
Sure. That's a great question. You know, everybody gets excited when we talk about TORS these days because of the success in oropharyngeal cancer. And certainly its role in laryngeal cancer or its potential role is exciting. But to be truthful, as of yet, its role is not yet well defined. It's been used principally to resect supraglottic and glottic tumors, not for subglottic tumors, mainly related to the very small field and the limited sort of visualization of this area. At a superficial look, TORS shares a lot of the principles of TLM in terms of technique. There are some potential advantages that TORS could offer. One is better visualization of the operative field, particularly when you're talking about the supraglottis, where you can get a fairly wide field view while magnifying the area of interest. And this is particularly important in large tumors where the boundaries can extend out of your field of vision when you're doing TLM. The ability to replicate the three-dimensional vision is also obviously very beneficial. Adjusting the endoscopic view of the robot is a lot easier compared to adjusting the microscope in TLM. And we've all had those microscopes that are sticky and our back hurts and our arms hurt. So for sure, from an ergonomic point of view, it's nicer. There are greater degrees of motion and movement that are available, greater dexterity as a result, more maneuverability. It also eliminates tremor. So if you've had too many cups of coffee and you're doing that microlaryngeal surgery, your residents may be able to see it. So you don't get that, obviously, with TORS. However, it is expensive. And in general, I think most studies to date have shown pretty clearly that certainly at this point in time, it's associated with an increased procedure time and a pretty long, what can be a pretty long setup time. In small fields in the area of the glottis and certainly the subglottis, the instruments are still relatively large and can crowd the surgical field. That being said, I think at this time shows most promise in the supraglottic area. And the European Laryngological Society classification for supraglottic laryngectomy can be used as a framework when using TORS. And this article, in fact, features some really nice drawings that illustrate the proposed resection for each stage. Complications with TORS remain a concern, and we've all heard about, those horrible situations where you have bleeding after TORS used in a tongue base, and this can certainly happen in the airway, and that can be catastrophic. So that's an issue. But it is a new arm under the umbrella of what we consider to be minimally invasive surgery. And I think, quite honestly, it's in its infancy. But at this time, I would have to say that TLM remains the gold standard.
Thank you. I want to almost take it back one step to talk a little bit, Gina, about tracheostomies, because sometimes these people are presenting with some degree of airway distress. Sometimes in the middle of their chemoradiation, they're getting some airway compromise. And sometimes you're just protecting the airway with a trach so that you can perform whatever it is you're going to perform in the supraglottis or subglottis. So where should that tracheostomy ideally be located? Like what's correct in terms of allowing for excellent airway while giving you, as the surgeons who are removing or the chemoradiation experts who are treating, enough room to actually do your treatment?
Anatomically, when we think of laryngeal cancer, whether the primary site involves the supraglottis, the glottis, or the subglottis, organ preservation is not 100% a guarantee for cancer cure. Patients can have recurrence, patient can have progression of disease, and persistent disease. So when providing an airway for a laryngeal cancer patient that needs surgical airway protection, and even prophylactically in treating a patient with a minimally invasive surgical technique, the primary spot is as proximal on that trachea as possible. So typically that's the first and in between the first and second tracheal rings. The caveat is patients that have subglottic cancer. Thankfully, that's a rare bunch of people. 1% to 2% of laryngeal cancer is subglottic in origin. And so you have to consider, again, anatomy for subglottic disease, because the primary lymphatic drainage basin is the paratracheal and prelaryngeal lymph nodes. So the Delphian lymph node directly overlying the trachea is going to be a lymph node that might have disease in it. So that's a consideration for possibly placing the tracheostomy one ring below, in between 2 and 3. But other than that, primary thought process is as proximal on the trachea as possible.
Fantastic. I think that's really important, because some of these decisions are not being made by people like you who are the, laryngeal cancer experts, but they're being made because somebody is in distress and somebody needs an airway. And I think just keeping that in mind is actually extremely beneficial.
It's ingrained in otolaryngology training. So otologists on call are going to take that into account. But, obviously we all treat patients that are from the community setting, and a general surgeon might intervene and perform that tracheostomy. But when it comes down to it, obviously an airway is an airway is an airway. But yes, keeping that in mind is also important.
Yeah, I think so. I'm pretty sure we've had the same dialogue 30-something years ago when I was in residency, talking about this, which, it's kind of nice that hasn't changed, because you're right. That's almost you could wake me out of a coma and I would know where to put that tracheostomy, which is kind of nice. We've talked, both of you have mentioned that although we all wish we could preserve the organ, especially the functional organ, that it's a lofty goal. And evidence shows that the risk of persistent or recurrent disease after a variety of organ preservation approaches for advanced laryngeal cancer ranges somewhere between 25 and 50%. So the next step would be salvage surgery. And that was covered in an article by Okafor, Awanosi, Watts, and Cannon. So, Karen, I was struck by the very high complication rate of 67% associated with salvage surgery following primary failure of therapy. So how is this explained, and what can be done to mitigate that risk?
I really can't argue with you there. I mean, 67% is a scary number. It's very impressive in a very negative way. And I think to understand that, we really have to go back to what happens when we give patients chemoradiation. And basically, what's associated with this treatment are profound, lasting, and in many cases, progressive negative effects on the larynx in particular and the body as a whole. So as a general description, what's happening is that the pathophysiologic effects of the chemoradiation are not just on the diseased part of the tissue, but really affect the entire organ with decreased vascularity, which we talked about a little bit earlier, hypoxia, leading to poor nutritional and immune status, and really leaving the patient with a very poor foundation for wound healing. And so this is, I think, the crux of the problem. And one of the most common complications, of course, is pharyngocutaneous fistula. And this is a really important one because it causes a huge amount of morbidity. So the morbidity consists of delayed initiation of oral diet. These poor patients can't wait to eat. And we're, making them wait another week, 2 weeks, 3 weeks, prolonged dysphagia, a delay in discharge. This causes a financial burden for many patients who have necessarily prolonged lengths of stay. And you can even, in the worst case scenario, have fatal sequelae, things like a carotid blowout, something we never want to see. The use of vascularized flaps in reconstruction in these patients might be helpful in, reducing the risk of pharyngocutaneous fistula, but then may also have a negative impact on later swallowing outcomes. So there's really no magic answer to this. The treatment is generally conservative. You have to drain the area, you have to pack it, and you have to wait for it to heal. Most of them will heal, but it can take a lot of time. And then, of course, we're not operating in a clean field, so surgical site infections are also pretty frequent. And other factors that may increase the risk of infection include, as you might expect, advanced age, poor nutritional status, poor indicated possibly by low albumin levels, and a history of tobacco and alcohol use. So you want to really try and optimize these patients before surgery as much as possible. And other late complications include, of course, stomal stenosis and pharyngoesophageal stenosis, which pose complications of their own.
So is there a role for hyperbaric oxygen as part of the protocol in these people?
That's a great question. So it's not something that's specifically discussed in this article. However, I think the role of hyperbaric oxygen at this point prior to surgery remains a little bit controversial. And certainly in our institution, the experience has been that it doesn't really help. I'd be interested to know Gina's experience, but we certainly do not use it routinely.
Yeah, we don't recommend it for, obviously, what we're discussing without saying is the fear of reigniting the cancer cells that might be present. But also, as in Karen's experience, particularly with respect to osteoradionecrosis, if it's that advanced, it's not helpful.
You had already mentioned, Gina, the Delphian lymph node, the sort of the pretracheal spread of disease. And we've limited this issue to the larynx, but you can't forget the primary drainage pathways for these cancers. So in the case where organ preservation has failed and salvage surgery must be done, can you talk about how the neck is addressed?
This is a very controversial area, like many things that we have discussed. But in the event of clinical nodal disease, the neck is addressed with neck dissection. That is not of dispute. But for patients without clinically evident disease, either by physical exam, which God knows by after treatment, it's very hard to distinguish clinically, but that even holds true radiographically because radiographic changes from prior treatment are also a confounding factor. But that being said, based on the evidence in the literature, there can be up to 30% of occult nodal metastasis, and that depends on stage. We typically don't restage patients, right? So a patient that was diagnosed and treated for T2 glottic cancer doesn't suddenly have T4 glottic cancer in the salvage setting. But what they do have is potentially progression of disease in addition to recurrent or persistent disease. And so that impacts the nodal drainage to that extent, right? And so I think you asked the levels of the neck that you would recommend in the elective neck dissection, as this would be in the setting of addressing occult disease. Typically, that would be a lateral neck dissection, which encompasses levels 2 through 4. There are studies that show that levels 1, level 5, and level 4 have less than a 3% chance of occult metastatic disease, and that's for either subsite. But level 2B is another example of yet controversy, right? It has been shown in a meta-analysis to have less than 1% chance of occult metastatic disease for supraglottic cancer. So technically, it's not necessary to address level 2B. When you remove lymph nodes, you are actually, in effect, reducing the blood supply, which, as Karen has outlined, is an additional risk factor for poor wound healing and the devastating complications such as pharyngocutaneous fistula. So when really making these treatment decisions, we have to balance the risks versus the benefits, and level 2B probably does not need to be done.
That's really interesting. So Karen talked about, free flaps or other types of flap reconstruction, maybe to bring vascularized tissue or bring, previously non-irradiated tissue to try to prevent some of this 2/3 complication rate. So the article by Kamki and Sajasevi provides a lot of accessible information. There's a really nice table there on the pros and cons of reconstructive options for total laryngectomy with pharyngectomy. So, Gina, when you're making these decisions, when do you make that decision? And is this a tumor board kind of situation? Is this do you have a 2-surgeon team for the extirpation and the reconstruction? Like, what is the patient experience when you're thinking about a decision like this?
Typically depends on how we meet the patient, whether that's an inpatient consult when the patient came in overnight, all of a sudden in need of a surgical airway, or whether we meet the patient in clinic. oftentimes when we're meeting a patient in clinic, they have thankfully been provided some discussion by their referring provider, which helps enable that conversation further. But at our institution, we have a laryngeal cancer pathway where when the patient meets with the provider on an outpatient basis, they're simultaneously meeting with a speech language pathologist. And so we are identifying patients based on the direct examination and extent of disease in determining whether or not that patient will benefit from additional tissue from a free tissue transfer. And I think even the providers that are not microvascular trained surgeons recognize when the extent of their surgical extirpation will require some additional tissue to provide a functional conduit for swallowing, as well as enough pressure to sustain voicing. And so the patient body habitus is one of the factors considered in determining what type of free tissue transfer, the extent, obviously, of the surgical extirpation, whether the patient needs a complete tube for reconstruction. And if that's a small lady with a small radial forearm, that patient will need an anterior lateral thigh, for example. So body habitus is a significant contributing factor, extent of disease. Other factors to consider, obviously, are the patient's medical status, because that can be a factor. Has the patient had prior treatment? There are many head and neck cancer patients who have undergone surgical extirpation, neck dissections for other head and neck cancers outside of the larynx. So they might have a vessel depleted neck, which might negate or complicate the use of a free tissue transfer. So there's several factors to consider. Obviously, you want to consider the patient's wishes. Sometimes the patient is adamant about not having a free tissue transfer for fear of the scar and the function. They might prefer to have a local regional flap. I think one of the great things about this particular article is indeed the table that you mentioned. Beyond the various types of local regional flaps and free tissue transfer advantages and disadvantages, they also have in one of those columns, they mentioned the success rate of the flaps themselves and the complication rates that Karen outlined previously in the table as well.
So thank you. I want to remind our listeners that we've been talking primarily about squamous cell carcinoma, but non-squamous cell carcinomas make up about 5% of laryngeal cancers. There's a really good discussion on the management of these tumors in an article by McNeil, and I really encourage you to read that article. So as we wrap up this fantastic educational session, and thank you both so very much, let's turn our attention to some vocal and swallowing rehab, because we started by saying, hey, the larynx, protects our airway, allows us to eat, and allows us to talk. So there's an article that you included by Tang, McCarroll, and Schmalbach, and they talk about vocal rehab. And the three major modalities for voice restoration are esophageal speech, an artificial or electrolarynx, and a tracheoesophageal puncture. So Karen, very briefly, let me ask you lightning round. What's your favorite method and why?
Well, I have to preface that with a small comment. So the small comment is that no one will argue that total laryngectomy has a profound effect on quality of life. But maybe we don't realize just how profound that effect is. And in one study, what they found that highlights this, I think, really well, is that 80% of patients with laryngectomies are aware of the stigma associated with their voice, and more than 40% experience social withdrawal due to communication changes and challenges. So I think it's just incredibly profound, and solutions to this, there are no perfect solutions at this point, but whatever we can offer is important. So the three options that you mentioned, my favorite would have to be, when it's possible, tracheoesophageal puncture. It's the most comparable alternative to normal laryngeal speech, or to normal speech. It doesn't sound the same for sure, but it is the most comparable. And patients, I think there's data to indicate that patients are fairly satisfied in the quality of the communication that they achieve with this. And it doesn't require, if it's functioning well, a lot of effort, and can be quite spontaneous. And, the advantage is it can be inserted at the time of surgery. And we now know that even if you're doing salvage surgery, doesn't seem to be necessarily an increased risk with putting in a primary TEP at that point. So that's also an advantage. Of course, patients who have trouble with pulmonary function, dexterity, poor vision are not really good candidates, and they will have to have either an electrolarynx or esophageal speech. And there are some problems. I mean, it requires lifelong care. They have to come for regular changes of their tracheoesophageal prosthesis. And there can be complications. You have to treat gastroesophageal reflux, which can affect the functioning of the prosthesis. If you get a candidal infection, it'll result in a leak, which has to be treated. So there can be some challenges, but I would say for sure, of the available options, that's the one that I think gives the best result.
I was recently at a meeting in Hawaii. I know it's a hard knock life, but it was the Pacific Coast Otolaryngology and Ophthalmology meeting. And being the nerd that I am, I sat there through all the presentations on laryngeal cancer and tracheoesophageal puncture, as well as otology. So one of their concerns was there's fewer and fewer people trained in how to replace, that routine management of a TE puncture. And how do you put that into your day? And one of the presenters said, well, his MA, his medical assistant, knows that when, Mr. Smith calls about needing a change, they just kind of shove them into the schedule that's already packed rather than having the patient wait months on end, throw them into any sort of available room, and he quick runs in, does the TE puncture change, and runs out. Is that what's happening at your institutions? Is it doctor-based, and can it be managed?
Well, I think that's a great question. And in our institution, it does not work like that. In our institution, the changes are done by our speech language pathologist. We've got an incredible team that works with us, and they're so familiar with these prostheses. So the patient has a scheduled appointment in the speech language pathology department, where they get their TEP changed, and half the time I don't even know that they're going.
And how about you, Gina? What happens in Jackson, Mississippi?
Same exact situation. Our SLP clinic is within our otolaryngology clinic, so it often is occurring at the same time, but we often don't even know, as Karen said.
And how much training? So one of the concerns that people were saying on the front lines at this meeting was that it was hard to train up SLPs in the speech language pathologists in the private sector or in the public sector, in the hospital setting, so that they felt comfortable doing it. How much training do you think is needed for this sort of compassionate, routine, necessary care that really shouldn't take a lot of time out of these people's lives?
So in my opinion, what we've seen in our institution, and I suspect this has happened in many others as well, is that similar to otolaryngology, where many of us are so subspecialized, our speech language pathologists are subspecialized as well. And so we have some who are dedicated entirely to voice. We have some who are head and neck speech language pathologists, and they're the ones who gain the expertise in doing this. And so I think the sheer volume really allows them to be very comfortable and competent. And they recognize difficult situations, and they're very close to us, as in Gina's institution. And they can just run over and say, hey, I'm not terribly comfortable with this. Can you give me a hand? Or what do you think of this situation? Or can you have a look and see if the prosthesis is well seated? But in general, I think so experienced that they really learn to recognize problems and be very preemptive in solving them.
So, we rely on our speech language pathologists, not just for, I hate to say just, TEP changes and teaching people how to burp and talk, but we rely on them a great deal to help our patients swallow again and have that quality of life of being able to sit at the table with the family and enjoy a meal, right? There's something so remarkably important about that as human beings and interacting with each other. So, Gina, we talked earlier about prehabilitation, and in the article you wrote with Brisson McKenna, Siddiqui, Adams, Afanasieva, Chered, Burns, Geronimo, and Mahdi, you go over the assessment and treatments in rehabilitation. And in that, you included some really great videos on FEAST, which is fiber optic endoscopic evaluation of swallowing, that accompany the article. So again, sort of a little bit more lightning round. Can you talk to us about oral versus pharyngeal versus esophageal dysphagia? Talk to us about different types of swallowing assessments that are used. And then what about the therapy strategies that you mention in this article?
Obviously, as clinicians, a good history can help start the pathway of discerning what type of dysphagia a patient might have. And that is accompanied, obviously, by physical exam and these additional studies that you've mentioned, beginning with FEAS and then modified swallow. But symptoms suggestive of oral dysphagia will commonly include kind of chronic mucositis, whether or not a patient has xerostomia, sometimes altered taste. And then on physical exam, you might find a patient has altered tongue mobility. Pharyngeal dysphagia, you might elicit from a family member of a patient that when that patient takes a food bolus, he or she might choke or clear their throat. Sometimes patients don't recognize they're doing that. It's just become a habit. They might have significant neck findings, such as lymphedema or significant fibrosis or stiffness and limited range of motion of their head. Fiber optic exam in the clinical setting might demonstrate, obviously, glottic incompetency and sometimes what we call internal lymphedema. And then patients with esophageal dysphagia might complain of food sticking in their throat or globus sensation. And that's an examination finding that requires some radiographic or fluoroscopic visualization to diagnose esophageal stricture. So that leads us to the various modalities for evaluating patients' phases of swallow. You mentioned the fiber optic endoscopic evaluation of swallow, or FEAS. That evaluation is very useful for demonstrating what happens with the larynx with respect to swallow. It does not provide an objective visualization of the oral phase of swallow or the esophageal phase of swallow, but it's highly sensitive for ascertaining whether or not a patient's experiencing laryngeal penetration or laryngeal aspiration. Both of these things can be mitigated with specific swallowing strategies, but really we want to identify patients who are not safe, who might experience a life-threatening aspiration pneumonia. A more comprehensive kind of evaluation is the Modified Barium Swallow Study, MBSS, or as I think my Canadian friends refer to it more commonly, VFSS, video fluoroscopic swallowing study, as I found out in co-authoring this chapter. This is a comprehensive examination where patients will be provided a variety of consistency of a bolus that's coated in barium, and several series of images are taken where the radiologist, in conjunction with the speech language pathologist, is evaluating these images. So it's really sensitive in identifying what phase of swallow, what anatomic limitations there are to this patient swallowing. You might miss some of the swallow, however, as it takes time for the imaging to reset. So you typically will have several series of images obtained for these patients with the various consistencies of food bolus. And then, of course, you can do bedside clinical assessment, which is a crude examination of a patient, but can be very useful for just ascertaining whether or not a patient's choking and not recognizing it. And so I think there's other kinds of studies that aren't typically used routinely in the United States, but might be used elsewhere, such as ultrasound. But I think the modified barium swallow study and the FEES are the most commonly employed and useful to us and our speech language pathologists.
So I want to point out to our listeners, if you go back and read this article, figure 1 is really great for distinguishing the site of dysphagia. Table 1 really lists those swallowing assessments. And then in particular, table 2 and 3 in this article detail swallowing therapy strategies, which I think would be great for you to share with the speech pathologists that you work with, so that you're all talking on the same page and you're all advancing the care of your patients. So, we're coming towards the end, and only now I'm going to ask you the first question that the patient and the family will ask you when you give them a diagnosis of, unfortunately, you have cancer of your larynx, which is prognosis. So the article by Han, Khan, and Maddie discusses this. So, Karen, how do you approach the discussion on prognosis? You already discussed some of the poorer prognostic factors that include continued smoking and drinking and toxin exposure in the air, reflux disease. But I'm really interested in why the prognosis has not really improved over the past 30 years. The 5-year relative survival remains 65 to 70%, all comers. So maybe how do you approach this prognosis talk, and what do you think we can do to for our next podcast on this topic have a better number there?
Great question. Again, I just want to say a word about how you approach the discussion, because I think it's incredibly difficult for patients to be told that they have cancer of any kind, and laryngeal cancer is probably the worst types of diseases that they want to have. And so I think, to take the words out of a song from a very famous Canadian band called the Guess Who, break it to them gently. And, be compassionate, be thoughtful, be empathetic when you talk to your patients. One of the things I don't like to do is give numbers. And so when patients say, well, for my stage of disease, what's the survival? And I almost refuse to say things like 50%, 60%, because I think it doesn't contextualize it for the individual patient. And what's really more important are the factors that are important for that individual. So I like to try and stay away from numbers. And you raise a very good point. Why, after all of these years, we've been having all this discussion, why are we not doing better? And I think that really comes down to the fact that our toolbox in dealing with this disease has not really changed. So sure, surgical techniques have evolved. They've become much more sophisticated, as have our means for delivering radiation therapy. But at the end of the day, it's still the same treatment based on the same principles. So clearly, I think the answer lies in another compartment of this toolbox that we are just beginning to pry open. And I think that's the molecular biology of the disease. And until we really understand that, we are not going to be able to develop appropriate therapies in order to influence survival. Fortunately, however, there's huge interest in this area. And I think we will be hearing much more about this in the years to come.
And, I think our listeners have very clearly heard the compassion with which the both of you approach your patients and their families when navigating this process, as we've talked about dysplasia and early cancer and advanced cancer and organ sparing and salvage and voice and swallow restoration. The fact that you chose to conclude this issue of Otolaryngologic Clinics of North America on laryngeal cancer with an article by Bod and McCammon devoted to palliative care and end-of-life concerns. And in that article, the authors say, for patients with advanced laryngeal cancer, the symptom burden includes societal shame, poor mental health, and disproportionate outcomes based on gender and race. And, there are some pretty famous people that I mentioned in my foreword who have famously suffered from laryngeal cancer. And in otolaryngology, we take care of many tumors that are either themselves visible or our treatment of them makes them visible. And in this case, this makes their tumor audible as well. So, Gina, these are tough conversations, right? We went into ENT surgery. We didn't go into hematology oncology. These are very difficult conversations to have. And they really do center around the otolaryngologist who is managing these patients. So how do you incorporate these type of palliation, end-of-life care into your patient treatment paradigm? And are there resources that the otolaryngologist or the head and neck cancer multidisciplinary team can reach to help patients and their families?
Well, let me preface my answer by saying I fell in love with otolaryngology because of a laryngectomy I saw and the relationship that I witnessed my attending, establish with the patient and the family, and just counseling the patient on what it meant, shepherding them through total laryngectomy, and then just a single postoperative visit. For me as the student, but I just fell in love with the elegance of the surgery from that standpoint. I think what better authors, I applaud Dr. Dodd and Dr. McCammon for this contribution, because it's incredibly important and something I wish that was a focus way back when I was training. But Drs. Bod and McCammon were so eloquent in their description of kind of the global comprehensive considerations that providers should incorporate in the shared decision-making of our head and neck cancer patients. You were just mentioning, Sujana, the significance of any head and neck cancer. And then more profoundly is the patient that is facing laryngeal cancer, whether or not the patient is undergoing a total laryngectomy, the possibility of requiring a tracheostomy in and of itself is a deterrent to wanting treatment or to even listen to what we have to say as providers. So it's a shame that in the United States, we're so work RVU driven that it limits our time with our patients in clinic. But our patients deserve a thoughtful, comprehensive, and compassionate discussion, really, of their prognosis, treatment options, and what it all means for this specific individual and their life circumstance. Oftentimes, this involves multiple visits back and forth in order for the first discussion about diagnosis and treatment options to really sink in and for them to digest that alone, as well as incorporating their family members and friends, their support system really into the discussion. I encourage the patients to come back with their support system to hear specifically from the providers, to offer them the opportunity to ask questions that their loved one, the patient, might not think of because they're so devastated by their diagnosis. And then to really ascertain with the patient and their support system what that patient's actual goals are. Sometimes the goals that we have as providers of providing cancer cure don't match up with the patient's goals, who they might just want to extend their life as long as possible and be able to do whatever they want without the consequences of the toxicities of the treatments that we have to offer them. I don't know about your places where you guys work, but some places, not the University of Mississippi, unfortunately, have outpatient palliative medicine services. I know that the term palliative medicine connotes kind of a negative feeling, but it's really a great resource to have, in that it's a group of providers that are really trying to shepherd someone from diagnosis through treatment, whatever that may be, pain management, all of the ancillary services that go into living with a life-threatening illness. And for us or others who do not have the resource of outpatient palliative medicine, we lean on our other colleagues in social work, in mental health, in integrative medicine, in physical medicine, anyone that really might, pain management, anyone that might impact the living of a patient with this diagnosis.
Very well put. I think I agree with you. I wish as a resident, I knew more about the sort of compassionate way that palliative medicine and the other specialties you talked about can work together to help our patients and their families reach their goals as best as we can. I want to thank both of you so very much. I'm Sujana Chandrasekhar. I'm Consulting Editor for Otolaryngologic Clinics of North America. And today I've been speaking with the guest editors of the April 2023 issue on laryngeal cancer, Dr. Karen Kost and Dr. Gina Jefferson. Karen is professor in the Department of Otolaryngology, Head and Neck Surgery at McGill University in Montreal in Quebec, Canada. Gina is professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Mississippi Medical Center in Jackson, Mississippi in the United States. You can find this and all issues of clinics at www.oto.theclinics.com or in your institutional library and maybe even in your personal library. And you can find all our podcasts online at either the clinic's website, www.oto.theclinics.com, or wherever you get your podcasts. Thank you both so much, Gina and Karen. This was really informative and just wonderful in every way. Thank you so much.
Thank you so much.
Thanks so much, Sujana, for hosting this. It's been really a pleasure chatting with both you and Gina about this really important topic.
Thank you for joining us for this edition of the Otolaryngologic Clinics Podcast series. For an exclusive discount on the issue we discussed today, focusing on larynx cancer, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Signs Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics Podcast wherever you get your podcasts.